So good evening, everybody, ladies, gentlemen, distinguished guests. My name is Ian Bruce. I'm the Pro-Vice Chancellor of the Faculty of Medicine, Health and Life Sciences. And it's my pleasure to welcome you here to Queen's University tonight on behalf of the faculty and on behalf of the School of Nursing and Midwifery for this inaugural lecture. Just before we start, just a few bits of housekeeping. First of all, can you make sure that your mobile phones are switched off and turned to silent? Also, we're not expecting a fire alarm tonight, but if one does occur, there's an exit over here as well as exits at the back, and we'll escort you to the place of safety outside. So thank you. I think an occasion like this is a very special occasion for Mary herself, but also for her family. I'm delighted to be able to welcome members of the family here tonight, including her husband Noel, her son Cahill, and his wife Catherine. And Catherine's sister is actually a distinguished author who studied at Queen's University and has written an award-winning novel called Snowflake. So welcome. Also, your sister Bernadette is here, along with her husband Tony, and your sister Frances, and your niece Emma. You've also got some close friends here, Sinead and Adrienne. Unfortunately, your daughter Louise, her husband Dara, and your granddaughter can't be here tonight, but we are recording this so they can watch you at a later date, hopefully. So I'm delighted to welcome Mary to give this lecture. So Mary is Professor of Aging and Intellectual Disability and Director of the Trinity Centre for Aging and Intellectual Disability and Executive Director of the National Intellectual Disability Memory Service. She's held many senior leadership roles in Trinity College, including being Dean of the Faculty of Health Sciences and Head of the School of Nursing and Midwifery. Professor McCarron is founder and principal investigator of the IDS-TILDA study, a longitudinal comparative study on aging in persons with intellectual disability, including persons with Down syndrome. This is a global first. The IDS-TILDA has increased our understanding about how lives with chronic conditions change over time for this population. It's driven change in healthcare practice as well as national health policy. Professor McCarron has also led a longitudinal cohort study of dementia in people with Down syndrome spanning 25 years. She is founder and executive director of Ireland's first dedicated national memory service for people with an intellectual disability. She's been a champion of patient and public involvement in research for many years and is principal investigator of a PPI Ignite programme at Trinity College, part of a national network amongst universities in Ireland funded by the Health Research Board. And she's received the inaugural HRB Impact Award. She's co-applicant of the HRB's Clinical Research Network Awards for Dementia Trials Ireland, which is setting up a world-class clinical trials infrastructure to support and grow dementia intervention studies. In addition, she's the Irish lead of the Horizon 2021 consortium working on clinical and trial outcomes and measures for dementia in individuals with Down syndrome. She's been a key advisor on aging and policy issues to various governmental bodies and has recently been appointed to the Commission on Care for Older People. She is a member of the Governance Board of the International Association for the Scientific Study of Intellectual and Developmental Disabilities and serves on a number of hospital and intellectual disability services. She's got in excess of 500 publications and is a real pioneer in this field. So I'm absolutely delighted to invite you now to come and give your inaugural lecture entitled Leadership in Academia, Health Research and Healthcare, Charting a Personal Journey. Thank you.
Thank you. Thank you very much, and it's a real honor, and I really want to thank you for this lovely invitation and for this appointment. And I very much look forward in the future to working closely with faculty at Queen's University and looking at some joint initiatives, I think, which we can pursue together. So thank you for that. I'm not going to present a very heavy science lecture tonight, because I think you can read all that in different places. I'm going to really chart a personal journey on the work that I've done over many years. Hope the slides move on. So We any technical person in the room? Oh, maybe we have to, does it? I just have to click some pieces. Okay. All right. So this is, I'm very privileged to have worked in this wonderful university at Trinity College. Hopefully all of you here, it's only a very short distance from Belfast, have had time to visit this great university. And it's been a real privilege for me to have worked there over the years. I think we'll have to get somebody to, yeah, okay. There are many prominent alumni, which we're indeed very proud of at the university. And many of them are famous names, which you will recognize, people like Jonathan Swift, Bram Stoker, Oscar Wilde, Ernest Walton, Samuel Beckett, and of course, our wonderful presidents past, Mary Robinson and Mary McAleese. For those of you who have yet to visit Trinity, you will see the old and new, the 16th century university with, I think, 21st century knowledge. And this is the beautiful Long Room Hub and its vast collection, including the wonderful Book of Kells, and then some of our more modern buildings as well. But I'm going to now talk a little bit about a personal journey. So this is me here back in the day when nurses wore hard hats. Do you recognize that from many of my nursing colleagues in the room and my medical colleagues? And I started my training at that time in intellectual disability nursing. And then I went to James Conley, did train in general nursing, and I went back to intellectual disability nursing. And it was there I became aware that there was a population who were aging that we seemed to know so little about. And no one was really, seemed at the time, terribly interested in knowing much about this population at the time. And this is another picture here of, at that time, Ireland awarded what was called Nurse of the Year, Lucozade Nurse of the Year, for those of you who are not too old to remember. And I'm showing you this picture, and as you can see here, many counties in Ireland claimed where I belonged, including Donegal, Noel, and I didn't put the picture of Donegal in, but I want to show it because at that time, the president of what was called An Bord Ultránis then, this is what she had stated: Mary has a clear sense of direction and above all else to help people with severe mental handicap to lead a happy and meaningful life. And it shows you, that's back in 1990, how the language has changed. We don't refer to people as a mental handicap, and we talk about learning disability or intellectual disability. But my mission throughout my career has not changed. And that was to help people with an intellectual or learning disability to lead happy and meaningful lives. And I want to say at the onset, I don't have anyone in my family with an intellectual disability. So oftentimes people who are so passionate about something, often it is the case. But life takes many paths. And this is me here, coming home from hospital with my son, Cahill, and my daughter, Louise, and husband, Noel. And at that time, I had, I suppose, climbed the ranks in nursing fairly young. And I was a ward sister, and people felt I was going to continue. And I actually felt I wanted to take a sideward step and go back job sharing, staff nurse on night duty. And I'm sharing that because many colleagues really struggle in terms of career and family, etc., both young women and young men. And people at the time said, Mary, that's career suicide. How can you do this? And etc., etc. And I'm showing this because I think you can do it. I did it for a number of years and it was really worthwhile. And you will see it didn't change what happened later on. But I was job sharing. So here I am back job sharing as a staff nurse on night duty. And of course, for those of you who know me, I'm very much a social animal. I'm a social being. So I love people and the patients had a great time. And it's a pity I didn't do a study on them. If I'd known about research, because they were up all night with me having cups of tea. And most of them were nearly cured in the morning because you heard all about the patient. You understood and you learned so much about what was actually wrong with patients. And I think if anything has happened in healthcare and in nursing in particular, oftentimes we have lost that ability to spend time and have those important conversations with our patients, which I think are so critical to well-being and health. And these are two great colleagues of mine, Professor Brian Lawler and Professor Michael Gill. And at that time, one of the consultants who I had worked with contacted both Brian and Ian, and they have remained lifelong friends, and said, we have a wonderful nurse, intellectual disability trained, and they were setting up the first longitudinal study on genetic risk factors for dementia in people with Down syndrome. And I went in and I'd done the interview with Brian and Ian, and they offered me the job. And I thought, on my way home, or later on, I thought, I'm a complete fraud. At that time, nursing was an apprenticeship model. There was no computers. I had not done my degree in nursing. So academia, literature searches, systematic reviews, and the use of SPSS and statistics was a foreign language. And so I thought, I don't think I'm the right person. But they convinced me that I was the right person because I really could communicate with people with intellectual or learning disability. I understood how to recruit them and also how to communicate with that population. And that was a very successful journey. And at that time, the first degree in nursing was happening. And I undertook my nursing degree at Dublin City University at the time, were the first to offer that part-time degree. And then these are some of the early science contributions back in 1995 to 1999. And I mean, it's just amazing to believe that that is so long ago. And I'm giving you the date so you can see the journey. And this is a bit of a slow burn. So you do need the perseverance. And I'll talk a little bit about that later on. But there's some of the key initial papers that we produced at that time. And of course, my background was nursing. So I had worked now with great scientists, and I really understood the neuropathology of dementia. I understood the genetic risk factors for dementia in this population. But I thought, well, what does that mean for care? How are we going to care for this population? And at that time, the Health Research Board were offering the first 4 clinical fellowships for nurses and midwives in the Republic of Ireland. And this was at the time when nursing and midwifery were moving into the universities. And we had all of our nurses and midwives were working in our hospitals, but they weren't at degree level or didn't have PhDs. So the big issue was to get people in and to get them trained up. And Professor Gill and Lawler encouraged me to apply, and I was successful in winning one of those 4 first clinical fellowships. So I ended up being co-supervised by medicine and nursing because we had no one. I was the first PhD graduate from the School of Nursing and Midwifery at Trinity, and we didn't have people to supervise at the time. And then, of course, I moved straight into the world of academia. So when I'm really feeling I'm overworked, I often say to the president of the university, I actually want to go back and be a postdoc. I feel I miss being a postdoc. And those in academia will know what I'm talking about. But I came into the School of Nursing, and the very first thing that I did really quickly was to develop a higher diploma in intellectual disability and dementia, to skill up people to be able to support and care for people when they develop dementia. I also was bought out half-time. Throughout my career in Trinity, despite all the senior roles I've held, I've always managed to be bought out. And I think that has been really good. It has kept me very focused. I really understand the issues on the ground, because sometimes we can enter into the world of academia and we really don't know, we're not embedded in what's happening. That has been a really important part of my work. So I worked then at a large organization who wanted to develop a strategic plan. And I developed a strategic plan at Avista and developed specialist dementia homes, which have had fantastic work with working with architects and engineers. I understood the neuropathology of dementia, and I understood what happened in the brain when somebody developed dementia. And I always felt, well, if I lost my leg in the morning, somebody would develop a prosthetic device to replace that leg. And I wondered, could we develop dementia homes that would act like a prosthetic device for those parts of the brain that were no longer functioning? And those homes have won Best Design of the Year and Best New Home of the Year. And it was just a labour of love and a complete pleasure to have been involved in all of that work. And then, of course, I was asked to take up the Director of Research straight away, as you can see. and then head of school. And at that time, we had most of our staff in the nursing school didn't have PhDs. And the big issue was, how do we get 50, 60 people skilled up? And I had great fun writing a strategy for research for the school, and brought in a cadre of visiting professors from all over the world who would supervise our academic staff. And as you know, since then, we have been very successful as a School of Nursing and Midwifery, and first in Ireland and top in the world, indeed. And then this is the landscape of Trinity. So in Trinity, we have 3 faculties: arts, humanities, social sciences, health sciences, and engineering, maths, and science. And within those faculties in health sciences, there is the School of Nursing and Midwifery, the School of Dental Science, the School of Pharmacy and Pharmaceutical Science, and the School of Medicine, with all the allied health professionals, OT, physiotherapy, dietetics, nutrition, etc. And I was asked by the then Professor Dermot Kelleher, who I know some of you may know in this room, would I consider putting my hat in the ring, voted in Trinity to be faculty dean, which is the same as vice chancellor in other universities, because it's just to do with the structure. And I thought, oh my God, I don't have the skills for this. I thought, I don't think I could do this role. And you're voted in by the faculty members, by the academic staff. And I went for it, and I was voted in. And all I can say is, at the time, I really want to pass on this message to you. So don't let what you cannot do interfere with what you can do. And oftentimes, so many of us spend the time thinking about what it is I can't do, so I can't do that job. And I feel that doing a poor job is not the enemy. It's the fear of doing a bad job that's very often the enemy. And when I took over as faculty dean, 2011, what was happening in this country? Recession, public funded university. The budget was halved. I was responsible for the financial situation. Zero-based budgeting was a foreign language to me again. So these were all new skills. And my best friend became the chief financial officer. And to this day, we're still best friends. So really, it is about just going for it anyway. So I was recognized then by the American Academy of Nursing and became a nursing fellow, which was lovely as well, back in 2020. But then how did I build and sustain a research portfolio, take it as well as doing all these very heavy administrative roles? Because usually when you're in senior leadership roles, you don't do research, and that's one of the big issues. But I felt the research needed to be done, and at that time we didn't have people leading out in Trinity in this area. So I had done a paper looking at mortality rates in the general population and compared them to people with intellectual disability using the census data. And I showed that mortality in women and across all the age groups were dying about 7 to 20 years earlier in general, people with intellectual disability compared to the general population. And this is really worrying, because that longevity gap that we've seen in the increased longevity in the general population, we're not seeing that in people with intellectual disability. And my colleagues, Anne and our colleague here, Roy McConkie, did a later study. And we also continue to show that people are dying about 20 years younger. So I began to ask, I don't know where it's gone to. Okay, all right, good. So this is a map of the world here. And all of those dots are the longitudinal studies on aging that have happened all around the world. And they all started, of course, from the Health and Retirement Study, the HRS study in the US, because we want to be able to compare how people age across the world in different countries and what are the determinants of health and well-being and what's different. Now, I was asking at the time, how come when Ireland was launching TILDA, and I know we have your Northern Ireland study on aging, and I was very disappointed I wasn't able to include a sample of people with learning disability in that longitudinal study. So I was asking the question, why is it that no country in the world has ever included people with an intellectual disability in tandem with a general aging study? So we now are the first country and the only country in the world that's actually able to compare how people with intellectual disability age compare to the general population. We're using the same outcome measures, the same protocol as TILDA. We have made some additions, but there's a huge ability for us to compare. And of course, people at the time told me, Mary, people with learning or intellectual disability won't be able to participate. It'll be too difficult. All the IRB issues, etc., etc. Go for it anyway. So this is us here now, and I really want to acknowledge my colleagues, Professor Eilish Burke and Professor Emer McGlinchey, who have travelled this journey very closely with me over many years and were there from its inception. So I'm delighted that Emer and Eilish are able to be here this afternoon. And we just launched Wave 5 report last November, and currently we're being funded by the government now, and we're now writing the grant for the next 2 waves, for the next 6 years. So we have, this is 15 years, and we will have over 20 years of data. And from the very beginning, of course, if you didn't involve, I felt, people with an intellectual disability from the beginning. So this was long before anyone spoke about PPI or public patient involvement or engagement. It just made common sense to me that we had to work with people with intellectual disability and try to see how we could do a study of this nature. So here you can see people inputting into the protocols. People with intellectual disability now train our field workers, are very involved in helping us to understand how you would interview somebody with an intellectual disability. And you can see Mei-Lin Yap here. And any of you that want to look at that short film, Aging with Pride, it is on YouTube. And it has had, I don't know how many thousands of views at this stage, where Mei-Lin produced a short film talking about the data and what the data means. And then, of course, translating the findings is so important. And Mei-Lin now is employed working with us at the Trinity Centre as our ambassador liaison officer. And we also have a second man with Down syndrome also working with us at the centre. And involvement matters to people with ID. Very happy to be involved. It's nice to have the chance to talk about the questions. I'm glad that people from Trinity College are here with us. I published a paper maybe 2 years ago looking at recruitment and retention in longitudinal studies, almost a 90% retention rate over the 15 years. Seldom seen in this type of research, really quite extraordinary. And in that paper, I talked about the hows and whats of all of that. And I was very happy in 2019 to accept the inaugural HRB Impact Award for, I suppose, our work and the translation and working with people with ID. And then this is our Wave 5 report, and that's all on the website, and you can download it. And I'm going to just give you a little snippet of some of the things that we found and that it said. And I'm going to look at multiple morbidity and physical health trajectories across aging. And self-reported health, and despite the fact that chronic health conditions were prevalent, most adults appraised their health as excellent or very good. And that's not unlike the general population. Despite health conditions, most people appraise their health as excellent or very good. And for those aged 50 and over, this statistic was even higher at 91% than that reported by TILDA for the general population. And just to say, we are following 10% of the total intellectual disability cohort aged 40 years and over. TILDA, the general aging study, are following people aged 50 and over. We are following people because of premature aging in this cohort, particularly those with Down syndrome. And we were really positioned in the Republic of Ireland to do a study of this nature because we have the International Intellectual Disability Database, which collates all people in Ireland who are in need of receipt of service, and we were able to get permission from the Department of Health to actually randomly select 10% of the intellectual disability population aged 40 years and over. And now, over subsequent years, of course, we have refreshed the sample. But here you can look at, I'm very interested in patterns of disease, and obviously we're always trying to break these disease groups and patterns. And you can see here that multiple morbidity continues to be an issue for people with intellectual disability. 72% of people with an intellectual disability over the age of 40 years presented with 2 or more chronic health conditions. But I think what's really interesting is that the pattern of disease is different. you're looking at gastrointestinal disease, mental health disease, neurological disease. Whereas in Tilda, for the general population, the patterns you're looking at are things like respiratory disease and cardiovascular disease. So it's really interesting. I think we have got a great understanding on the aging and health issues for people, particularly those with Down syndrome and dementia, who has really helped our understanding of things like Alzheimer's disease. But it's really interesting to me that people with intellectual disability, despite the risk factors for cardiovascular disease in terms of overweight, obesity, etc., hypertension was nearly half what it was in the general population, measured hypertension. So what's driving some of these? And I think it is in populations like this that we can get a greater understanding of some of those key issues. We have a new academic working with us now looking at cancers. Why is cancers different? What's different about the types of cancers? So these are all really, I think, fundamental questions, and we have the ability to look at some of these issues. Things like chronic constipation, I think this is worrying and really concerning. You can see there in the under the age groups, the under 50s, and then the 50s to 40 to 64 and over 64. So you can see here that from wave one, the prevalence increased from 7.3% to almost 43% across the 5 waves. And this is really, really concerning. And even in the under 50s, those 40 to 50 years, chronic constipation is really high at 34% and has really increased over time. So this is a very worrying trend. And what's really interesting is that level of intellectual disability and mobility were significantly associated with constipation while age wasn't, whereas in the general population, age is the driver of some of these issues. So there's a real opportunity here for a bowel intervention programme, and I'm delighted to see that my colleague, Professor Eilish Burke, is working with a cadre of advanced nurse practitioners across different services now, looking at a bowel intervention to try and address these issues. Because really what we see was the main approach to management was pharmacological approaches to the management of chronic constipation. So 40 of those with chronic constipation, 42% reported using laxatives, and of those using laxatives, 40% reported using 2 or more laxatives. And what we found was that factors associated with laxative use included anticholinergic burden and soft and liquidized food intake. And we are very privileged that we are working very closely with our colleagues at the School of Pharmacy and Pharmaceutical Sciences, who are leading out now. They have a group called the Medicine Optimization Group, and they're leading out on the medicines. There's a whole host of publications. Anyone wants to see all of the stuff around health, please look at that. And this is musculoskeletal health, which is Eilish's particular area. And again, I think in wave one, we found a big discrepancy between doctors' diagnosis of osteoporosis and objective measures. And while people like me who are scientists don't like to think that there's, any intervention being part of a longitudinal study. But of course, the reality is when you're asked so many questions and people say, well, should I have a DEXA scan? Do I need a DEXA scan? You can see that people, certainly it didn't improve. But nonetheless, it is a worrying picture. And of course, people with intellectual disability have many different risk factors which really predispose them to chronic constipation, including high levels of epilepsy, many of the anti-epileptic medication, many of the other issues, immobility, etc., etc. But it's also important to note that men with intellectual disability were 12 times more likely to present with objective evidence of osteoporosis than men in the general population with data from TILDA. And I could spend all night telling you why that is, but that's not the object of tonight's talk. And again, Eilish has did a huge amount of work in terms of translation and presenting, developed an online MOOC and different interventions to help us understand on how to do accessible health assessment for this population. In wave 5, I really wanted to focus on women with intellectual disability and to see what was happening for this group of people. So what we have seen was that females were much more likely to be multimorbid than male. They were significantly more likely to have 3 or more chronic health conditions. They were significantly more likely to have joint disease than men. are significantly more likely to have osteopenia and the prevalence of osteoporosis. So women were in poor health. I spoke earlier about them dying 20 years earlier than the general population. Women were also significantly more likely to have depressive symptoms than men, higher levels of anxiety, and there was a larger increase in anxiety for women from wave 3 compared to men. Loneliness was more common, and female remains more likely than men to report continued and sustained loneliness, which is a real issue. And then I was interested in menopause. We had a spotlight on this for the general population recently. So the mean age of menopause in women with Down syndrome was 44 years and 48 years for women without Down syndrome and 51 for the general population. 41.6% of menopausal women with ID reported symptoms of menopause, and that compared to 90% in the general population. Well, as a woman, it's not for 1 minute that I think that women with intellectual disability didn't have symptoms of menopause. I think they lacked the voice to actually be able to report what was happening in their bodies. And when I speak a little bit later about medication use, we need to get under the bonnet of what's happening in terms of mental health and distress. Less than half of the women were aware of menopausal transition. Just over a third had discussed menopause with anyone. And over 80% of women said that they didn't receive any information on the menopause which they could understand. So I think we have room for improvement. Now, this is the Women's Health Action Plan. And without targeted interventions, the morbidity and mortality gap for women with ID will continue. Ireland's Women's Health Action Plan, women with ID need to be specifically included and targeted. And education is needed for the women themselves, and awareness of these risks needs to be increased amongst healthcare providers, practitioners, GPs, etc. And we're delighted now that we have a new PhD student and a number of people now working on the area of women's health within the facility. Again, as I said, medicine optimization. Myra Dwyer is leading out in this. Myra again was a PhD student with us and has now got a faculty position in the School of Pharmacy and Pharmaceutical Sciences, and she continues to lead this. But I just wanted to show you a little bit about polypharmacy and excessive polypharmacy and what that looks like. No polypharmacy, as you know, is 0 to 4 medicines. Polypharmacy is 5 to 9 medicines, and then excessive polypharmacy is greater than 10 medicines. People with an intellectual disability were 10 times more likely to be exposed to excessive or hyperpolypharmacy than in the general population. So this is a real concerning issue. And these are the drugs that are driving polypharmacy and excessive polypharmacy use. And as you can see here, the antipsychotics, anti-epileptics, and laxatives. And what's really concerning is here, not only are people on one drug, you see multi-agents, 2 and 3 agents. And we know all the issue about multiple drug routes, interclass polypharmacy, and the issues for this population. And you can see the difference in the drug use in the general population. So exactly, it was the lipid modifying agents, the angiotensins, the antithrombolytics, a very different pattern of prescribing between the two groups. I'm delighted now that Myra and her team have got further funding through the Health Research Board, and we're doing a project with the HSE National Clinical Programmes and the Learning Faculty College of Psychiatrists of Ireland and clinicians and stakeholders called the EQUIP study, which is around deprescribing and understanding medication prescribing for this population. So that's really exciting work. And again, this group have published in excess of 80 publications since Myra did her PhD with us, and that is not very long since the start of IDS Tilda. So they are fantastic. Oral health, again, we are lucky to have the School of Dental Science. Kevin Gillifordrick is a dentist. He did his PhD with us at IDS Tilda. He has got a permanent faculty position in the School of Dentistry and Dental Science and leads the oral health arm. And here you can see that 28% of people with an intellectual disability reported that they had no teeth at all. This compared to 16.9% in the general population with data reported by Tilda, but 67.8% of people with intellectual disability with total tooth loss did not receive prosthetic dentures. they were orally disabled. And this compared to 5% in the general population with data from TELDA. What we found was that those who were totally edentulous or orally disabled were twice as likely to have difficulty in eating, no surprise, 3 times more likely to be in a soft and liquidized diet, and twice as likely to report chronic constipation. So there's this revolving circuit for this group of people. And this was despite that this population used dental services way more than the general population. 91% had visited the dentist in the past 2 years. 91% reported that they brushed their teeth, but there was a range of supports needed. And 58% said they had oral care plans. So home care appears to be ineffective and national training is needed. And we're not really sure what happens to the population when they actually go to the dentist. Are they much less likely to have restorative treatment or exactly what happens? So Kev and his team are doing and have continued to do, and we have now a programme supported by the HSE, the Health Service Executive in Ireland, where we are working closely with them in terms of an oral health intervention programme. Again, a host of publications associated with all of this. I could talk forever about the data from IDS TELDA, and they're some of the physical determinants, but the social determinants of health. We have a very large conceptual framework underpinning this study, and we have huge data on the social determinants of health. Dr. Darrell McCausland is a sociologist. He's leading out on the social determinants of health. He did his PhD with us, and he has got a joint appointment now between Trinity and one of the large care organisations in Ireland in terms of trying to translate the issues on social determinants to make a difference. And what we have seen was that most people with an intellectual disability were socially active and they had strong social connectedness. The key difference in social networks, though, versus the general population, many of this population, over 99% of them, had no spouse, children or grandchildren. And for all of us, we know how critical they are in our lives. And the big question is, if you look at any of the ecological models on aging, is asking how will they be replaced and those important social networks in the lives of people with ID. Inclusion and community participation often depends on parents, on siblings and on paid staff. We have a very large caregiver arm because we're interested in trying to understand the tipping effects for family caregivers and what really predisposes family caregivers and puts them at risk to relinquishing care. Evidence of improvements between generations. We're able to look at intergenerational differences now. Look at the 40 to 50-year-olds today versus what they were like 15 years ago, 20 years ago, and really begin to track if policies have made, what has the impact of policies have been. And we can certainly see that there's improved choice, better community engagement and decreased loneliness, but there's continued exclusion compared to the general population. Very few are in real paid employment, voluntary work, and there still remains a large digital divide in their ability to use and access technology. And what's really concerning is that those with severe to profound intellectual disability and non-community residents remain the most excluded. So if you have a severe to profound intellectual disability, you're much less likely to live in the same neighbourhood as any of your family as you get older. And that's very different for many of us as we age. Our family are inclined to move into the same community as we are. And again, translating the evidence, and here we are partnering with joint appointments with Stewart's Care to try and look at some of those translational issues. So from the very beginning, I think I was very thoughtful about translation, impact and capacity building, because when I started in Trinity, there was very little work happening in this space. And I know this is, my colleagues from nursing, and I know there's a lot of work happening here in Northern Ireland as well in terms of the future of learning disability nursing. I was commissioned by the department to conduct a study looking at the future of intellectual disability nursing, and IDS TILDA was a huge part of shaping what that looked like. And we produced that report, and a fantastic action plan has followed on that, and we have made fantastic progress. And some of you may be aware that this report was just issued by the Department of the Chief Nurse last week, and a strategy on nursing. And you can see that the Shaping the Healthier Future report was one of the key documents informing this more recent strategy. But what I'm really pleased about, when we did that report, which was only done in 2018, then we had to develop an implementation plan and get it costed and go through all the usual. Then COVID happened. But now, since then, we now have 26 advanced nurse practitioners in the Republic of Ireland working across all of these areas, and 99 clinical nurse specialists. So I think that is fantastic progress and really great to see that happening. I started off my career with dementia, and I think I'm finishing my career around the area of dementia. And this was a 20-year paper that I published, and I think it had a fundamental impact on the field, where I looked at risk for developing dementia in Down syndrome according to age. And I showed 23% risk at 50 years, 45% risk at 55 years, and an 88% risk at 65 years. So people with Down syndrome are the world's largest genetically predisposed population to develop Alzheimer's disease, yet they have never been included in clinical trials. And if there's ever going to be a treatment or a cure for Alzheimer's disease, this population convert. And they're a really, really important population in trying to understand what is happening in terms of dementia. So to me, I needed, again, to build human and academic infrastructure for this to happen. And without a national memory clinic, probably it wouldn't happen. And here I am, after presenting to the Oireachtas Committee on Health, and standing next to me is our now Minister for Older People, Minister Butler, carrying that plaque, committing that she would invest in dementia care in people with Down syndrome. And she's now our Minister for Older People, and I work very closely with her. And I work very closely across the country with intellectual disability service providers. I'm very connected to the community and work very closely with them. So after each wave of IDS Tilde, we sit with various groups. We try to help them to understand what this data means for services and for care. And we decide what is the one thing we're going to tackle in the next 3 years between waves. And at that time, we felt it was dementia, because many people, despite the risk of developing dementia, could not access timely assessment or a memory clinic. The general memory clinics only seen people maybe age 65 and over. They also felt that they didn't have the skills or the expertise in seeing or assessing people with Down syndrome. But I managed to get the data from IDS Tilde into the Irish National Dementia Strategy. And again, this is about the long burn. That strategy was published in 2014. But nonetheless, there was specific mention of people with Down syndrome within the strategy. And what I'm saying to researchers in the room is, if you don't get the data into policy at the time the policy has been written, it's too late when it's written, because the train has left the station and there will be no resource or attention to that. But because we were in the strategy, and Ireland then embarked on developing a model of care, there was an NGO set up and a model of dementia care was set up. And there was specific targets in terms of setting up a national intellectual disability memory clinic with satellite services throughout the country. And we set this up here. Professor Sean Kennelly, a good colleague of mine, is the clinical director of that service. I serve as the executive director of the service. I'm brought out at Trinity 1 day a week as they serve as the executive director. And my mission now is to develop satellites throughout the country. But we will be this centre of excellence, and we will develop the standards for both assessments and diagnostics and post-diagnostic care. And we work very closely with the Avista organisation, a large service provider who had really good experience. And this here is 3 RNIDs who completed their AMP training and are now 3 AMPs who really do much of the running of the memory clinic. And we also have a number of other professionals working there as well, neuropsychology, OT, speech and language, and we're a permanent line now in the estimates going forward. And I think that is really fantastic. And people now, no matter where you are in Ireland, with an intellectual or learning disability, you can come and get your memory assessed and good post-diagnostic support. And this is, again, building capacity and looking into the future. This is Dr. Emer McGlinchey. Emer is here, and Emer's background is psychology, and she did her PhD with us, and she also has a permanent faculty position. And Emer now is continuing to lead out on the whole area of dementia, really looking at examining early biomarkers and really looking at validating assessment instruments. Because the idea is, if we go to embark on clinical trials, we need good outcome measures, we need them across Europe, we need to link the data across Europe. I've been part of this Horizon 21 consortium, and Emer had just worked with them and invited them over to Trinity last week, and we did fantastic work. So I think this is really exciting for the future. Now we have the human infrastructure with people, and we have got the clinical infrastructure to do much needed trials. And this is what Maylin Yap had to say. Maylin is our Ambassador Liaison Officer. Like everybody here, I have dreams for the future, and there are things I want to do, and I know dementia might play a part in my life too. So when you start talking about dementia, I want to be included in that conversation. I want to be included in the conversation about my future. I want to be empowered so that I can choose how to reduce the risk of dementia. And we are doing a huge amount of work on brain health. We have our own PPI panel with people with ID. So it's a very powerful machine now at the moment in trying to push that agenda. So in total, this is many of our PhDs here who have just came through the system. We have 20 PhDs, 12 MScs, 9 postdocs. 9 of our postdocs have transitioned into faculty positions or to full-time research positions. And I think that beholds really well for the future. So as somebody had said, you have a lot of publications. And I think it's really interesting in this field that 42% of the publications are in the top 25% most cited worldwide. So I think that's been really great. 92% of them was international collaboration. I have managed to secure in excess of 16 million in research funding and member of various consortiums and organizations. So I hope I can bring some support to Queen's University over the next number of years. The Department of Health and has recently commissioned appointed members to the Commission of Care and Older People, and this is Minister Donnelly and Minister Butler. There's 12 people on this commission, and I am appointed onto that commission, where we're really hopefully flying the flag for people with an intellectual disability. So that's interesting. And this is really around all my career, and because I was Dean of the Faculty, I've seen such a problem in universities with lack of succession planning, and indeed such a problem across the health sector with lack of succession planning. So planning for sustainability. So this is many of our graduates, and as you can see, they're from right across the schools in health sciences, right across the schools in the university, and indeed in other universities. But together they have 195 publications, over 3,000 citations, a lot of social media mentions, and there's 105 policy citations. And I'm just given one policy citation for every one of these academics I have listed here, but altogether there's 105. And I think that is to be commended and beholds well for the future in terms of sustainability. Building the physical infrastructure. So we have now the clinical infrastructure, we have the human infrastructure with people, but I wanted a centre within the university. So I've managed to convince the university to set up a dedicated centre to study the ageing of people with intellectual disability back in 2017. And this is a thriving centre now. And we launched our last strategy in 2023 to 2028. And the vision is to enhance the well-being and quality of life for people with an intellectual disability as they age. And that's what's really important. This is a map of the world. And as you can see, we have many collaborations with various countries. This is us last year, the year before, signing an MOU with the Erasmus Medical Centre in Rotterdam. We do huge work with that. We're also bringing the World Congress to Ireland in 2027, and we will look forward to working with our colleagues in Queen's and indeed in Ulster and other universities to decide what the shape of that Congress should be. So just to summarise and to finish up, my take on leadership, as I say, vision without action is merely a dream. Action without vision just passes the time. and vision with action can change the world. So I have climbed up a difficult and shaky ladder, as I said, and I spoke about that. Many small steps, some of them with luck, some requiring perseverance and grit, and others to do with skill and application. But what I have learned, and hopefully you got that from the thread of I've presented, was consistency of thematic interest over time. And for me, that was the aging of people with an intellectual disability, perseverance of effort, and stickability. So I would say to make your way, identify your interests, prepare for the challenges and stick with it, develop your skills, apply your learning, mentor and be mentored, say thanks and demonstrate appreciation. So I always say that the standard you walk past is the standard you become. I think that's really important. So leadership is a process of social influence which maximizes the efforts of others towards the achievement of goals. So I worked very closely with my colleagues in the Department of Health, the HSE, service providers across academia, and that's really the key. It's really an important trait. And you need to be invested in your team. I see my goals as developing the careers of others, that I can slip away and I won't even be noticed. And be disinterested in power. Power, I think, is a very dangerous issue. And across my career at this stage, I can see really good organizations and really good ideas which didn't thrive because of people's obsession with power. And be interested, less in power and more about the goal and the ambition. And integrity and trust is really important. So what I did, and some reflections on my journey, I set goals and I stayed focused, but you may need to turn down other you may need to turn down other opportunities that distract you from achieving this goal. So I had an approach from the department to see what I do is study in children. No, I can't, because, sometimes it's just not where, it's not the best thing, or giving you money or getting a grant to do something that completely distracts you. I had a lot of self-doubt along the way, and I felt the fear, and I went with it anyway, and I've given you some examples of that. Expect and accept criticisms, the skepticism, the resistance, and learn to manage uncertainty. I think that's really important. I surrounded myself with positive people. You come into TCID and you can feel that energy. I always said in every management role I had, negative energy saps your energy. And I really want to accredit that philosophy to my mother, who isn't with us anymore. But all during my childhood, she would say, oh, that negative talk, Mary, is bad for your health. And that was long before anyone understood those issues. And have a group of people around you that you trust and you can lean on for advice and support. Build your team and judge your own success on their development. Oh, going in the wrong direction. Don't let it take over your life, your family and friends, and have other interests. And have fun and laugh along the way. And this is my gorgeous family, my children when they were small, my husband Noel, who's sitting here, my friends and cousins and relations who are all here, my sisters, my daughter who isn't here up at the top, and other family, and my dogs. And this is my gorgeous granddaughter, Roisin, who's away on holiday, and my son, Catherine and Cahill, who got married earlier in the year. And this is me. I'm an avid sports person. And this is me here, lifting up the bike after cycling last summer from Prague to Vienna as a fundraiser for the Irish Hospice Foundation. So have fun along the way. So this is your team, and developing the team and developing a sense of community is key. So it's not all about the big grant. It's not all about the big centre. It's not all about winning those, but it's how you win. And the people you bring along with you on that journey is the mark of real leadership and success. Thank you.
Mary, it's a real honour and it's a privilege for the School of Nursing and Midwifery here at Queen's to have you as an honorary professor within our school. As you've heard, Mary is an international leader in terms of intellectual disability, particularly with IDS Tilda, which is the global forefront and a global runner in terms of intellectual disability research. I first actually met Mary through the All Ireland Institute of Hospice and Palliative Care, which is based at Our Lady's Hospice in Dublin. And from the first time that I met Mary, one of the things that really struck me was how generous Mary was, both in terms of her time, but also in terms of sharing her expertise. And we can see that so much, Mary, in your presentation this evening. So I'm really delighted to bring the lecture to a close this evening. And I just want to add, Mary, that this has been really inspiring. Your talk this evening has been really inspiring. The work that you have done in leading academia, your nursing leadership in the face of this, and the roles that you have held have been really instrumental, I think, in moving intellectual disability, but also the profession of nursing forward as well across the island of Ireland. So finally, it's really our pleasure to invite you to join us next door for some refreshments. But before we do that, Mary, I just have a small gift that I want to give you as well.